So I think we now are already in the next session here, and I think we can go on now with the talk, if I'm correct. Mm-hmm. Yeah, I would like to ask Dr. Parekh to come to the speaker desk and to give his talk on endovascular versus bypass options for critical limb ischemia, update on several ongoing trials.
Thanks very much, Dr. Scheinert. So in the next few minutes, I'll just try to bring you up to speed on a couple of trials, one you may have heard of, one you may not have. My disclosures. So I think when looking at trials in the critical limb ischemia space, looking at endovascular versus open surgical revascularization, this is sort of the headline that has been with us for over a decade from the Basel trial, which is now in its second and third iteration. Unfortunately, the United States guidelines, and this eye chart is really meant to tell you where we are in the U.S. in terms of guidelines. There's very little granularity about how one might choose open versus endovascular revascularization for these patients. And so there's a couple of new data points in this trial, the so-called SPINACH trial, which was published earlier in the past year in Circ Interventions, is an interesting study out of Japan with a large retrospective assessment of 3-year outcomes in patients who underwent critical limb ischemia either via surgery or endovascular therapy. To summarize the trial design, this was about 550 patients with critical limb ischemia, 351 of whom were scheduled for endovascular therapy, and about 200 for surgical therapy, who were subsequently propensity matched and on an intention to treat basis were compared in terms of outcomes. The primary endpoint was 3-year amputation-free survival, and I think that's an interesting point in itself relating to earlier talks from the session this afternoon. And the enrollment was relatively contemporary within the last 5 years. Importantly, the Wi-Fi classification was adapted and used quite effectively to assess and quantitate the degree of ischemia, wound caliber, and infection as part of the stratification of the patients. Critical limb ischemia, importantly, was defined as the following, and I think this is similar in many trials: chronic ischemic rest pain with ankle pressures less than 50, toe pressures less than 30, perfusion pressures less than 30, or those with ulceration or gangrene as listed. And there was a sort of a cop-out definition also of rest pain or ulcer gangrene with critical ischemia indicated by other modalities other than the hemodynamics delineated above. The clinical results, and I think this is the headline, is that in this top panel, the amputation-free survival between groups was not significantly different. Importantly, there was also no significant difference in major adverse limb events, which will be germane to the next trial that I'll talk about. However, there was a trend that endovascular therapy, shown here in red, was slightly better than surgical therapy with respect to limb events. Paradoxically, there were fewer minor amputations in the surgical group, as shown in the third panel here, designated C. When looking at wound healing and survival in these two cohorts, the surgical group and the endovascular therapy groups respectively, you can see an appropriate wound healing trajectory after revascularization in both groups. And there's a slight uptick, which may or may not be a trend at the tail end in the endovascular therapy group. Similarly, you can see that there is a significant mortality, and in this lower panel, both mortality and amputation-free survival are summarized. And you can see that there, as time passes, there's a rising mortality associated with this high-risk patient population. I don't think that there's a lot to take home from the forest plots. As you can see, very few subgroups stood out as being favored for surgery, except for a handful. And the big downside of surgical therapy, as one might expect, is perioperative morbidity and mortality. However, here there was no statistically significant difference other than for surgical site infection in the surgical group. The most important take-home, I think, from the trial is that they were able to develop a scoring system using a few key multiple regression analyses, and using this strategy of giving a negative point for the following 5 things: non-adherence, anemia, diabetes, renal failure, and contralateral amputation. These characteristics favored an endo approach. And in contradistinction, Wi-Fi class W3 or infection 2/3 were predictors for superior outcome with surgery. Similarly, history of minor amputation, prior revasc before onset, and bilateral critical limb ischemia favored surgery. And I think this stratification might actually be clinically useful for us taking care of patients. The BEST-CLI trial, I think, is well known to many of you, and in 2 minutes I'll try to summarize the current status. As of last week, over 1,367 patients have been randomized in this over 2,100 patient target trial. As you know, these will be in almost 160 sites around the world, predominantly in North America, who will be randomized to surgical bypass versus endovascular therapy, broadly defined. In terms of the number of sites that are stably enrolling now, it's over 130 sites that are actually still open and enrolling across North America, as well as a few in Europe. There have been some important protocol adjustments, and this is reminiscent of many NIH-sponsored trials, that as the trial wears on and enrollment is difficult, liberalization of the enrollment criteria has to be done. And so the diagnostic angiogram has actually been eliminated, and axial imaging has been now allowed to be used for enrollment. Payments have been increased to help with excessive travel, and we've been doing a better job with following up the patients. There have been some clarifications on the definition of critical limb ischemia, and most importantly, and I think excitingly, there was a recent investigator meeting that has served to not only engage our federal agencies here in the United States to align our resources and our interests in the results of the trial, but also to goose the enrollment. And there was good representation with a lot of discussion about the value proposition in addition to the clinical outcomes of the study. Just interestingly, there's two cohorts. One is with saphenous vein, one with prosthetic conduit, and we're doing well in enrollment in both. Interestingly, there is an equal smattering of rest pain and tissue loss patients, and a demographic that I think is reflective of the United States, with a significant Hispanic population and a 30% non-white race population, with 30% women, higher than what might have been expected, but was in accordance with what was predicted. So I think with that, I'll conclude that the SPINACH trial has brought us new insights into what we might come to expect with the BEST-CLI trial, and we're probably still about 18 months away from concluding enrollment, and probably 2 to 3 years away from seeing results in BEST-CLI. Thanks very much.